Thanks for having me. So I think well, I know the title of this seminar series is Global Health and Ethics, and I'm gonna half disappoint you because I will be talking about global health, but I'm not sure there's a lot of ethics in this talk. Although, as I've come to learn, there are often ethical implications of things that we don't really think about. Anytime we think about resource allocations, we're talking about ethics. And what I'm going to talk a little bit about here is resource allocation. But OK, so let me give you a little bit of the motivation. So I'm going to do a few things. I'll give you some motivation for this presentation, tell you a little bit about the SARS epidemic, talk to you about why I'm interested in the SARS epidemic, what my research agenda is with respect to the SARS epidemic in 2003. And then I'm going to pick out one component of the epidemic that I'm going to tell you about, where I think I've got enough data to stand in front of a room and talk in a somewhat convincing way about some results. OK, so the precise question I'm going to ask is what the role of social learning is in explaining risk avoidance behavior during epidemics. So what do I mean by that? By social learning, I mean learning not from things like reading books or necessarily going on the internet or reading journal articles. There's some social role in there, social interaction there. But what I'm really interested in is the information that we learn from our peers. So me talking with you and you sharing your information about an epidemic, whether it's H1N1, SARS, whatever, with me. And I'm interested in the role that sort of conversational interaction plays in people's assessments of risks from new epidemics. Right? And so why am I concerned about this? I mean, it should be pretty easy to understand, especially now. Right? We have a new epidemic, H1N1. People don't know what the risks for H1N1 are. What is the probability that you're going to get it? What are the consequences of getting it? Is it going to come? So I'm actually thinking about what happened last spring. I wasn't just worried about was I going to get it, were my children going to get it last spring, and what the consequences were, but also, well, if I got it then, what would happen if it came back in the fall? What would be the interaction between my getting in the spring and my chance of getting in the fall? Would the fall be worse than the spring? Things like that. And I got to tell you, I think that was a more informed way of thinking about it than I think a lot of people think about, we're doing or we're engaging in. But the one persistent feature I saw in people's discussions, informal discussions about this, was uncertainty about these things. And one natural response that people had was that they asked other people. Sometimes they'd ask their doctors. Sometimes they'd ask their friends. They'd often come to me just because they knew that I had written a little bit about the economics of epidemiology, and for some reason thought that meant I'd know anything about H1N1. So I thought that was kind of interesting, and I thought that we need to understand why it is that people go and ask other people. One reason could be that there's just a lot of ambiguity. You don't have a lot of information. There's very little objective information. You don't have a lot of expertise. So you go to any source of information you can find, and one of them is social learning. The second reason is because I think social learning has some interesting effects on epidemics that I don't think we fully realize. And here's my concern, and this really came out of my research on how on basic models of how epidemics spread. So we know one thing, right? So whether or not an epidemic spreads or persists depends on the basic reproductive rate of the epidemic. So the number of people that an infected person subsequently infects. And we all know that if that's greater than 1, the epidemic spreads. If it's less than 1, it doesn't spread. And of course, not everybody is going to have the same reproductive rate. So there are going to be some people that are more high risk, some people that are less high risk. They'll have a higher reproductive rate or low reproductive rate. That is to say, the infection in them will have a higher reproductive rate or low reproductive rate. And so we also know that if different people have different reproductive rates, even if the average reproductive rate is less than 1, a disease can still persist and spread, because there are some people with above 1 reproductive rate. That's fine. That's not that deep. We also know that there's a problem if there's spatial correlation in reproductive rates. That is to say, not that we just distribute the high-risk guys and low-risk guys throughout the population evenly, but rather we cluster them. So high-risk guys hang out with other high-risk guys, low-risk guys hang out with other low-risk guys. That means the disease can spread very quickly among the high-risk guys because they're concentrated. It's like putting a bunch of fuel together for the fire, right? Now, the thing is, we always used to think, or at least the literature largely thinks, that sort of clustering happens in the case of certain epidemics, but not others. Like a classic example is, take STDs or HIV. If the high-risk guys hang out together, they're going to have there's going to be the disease is going to develop very quickly among that group. But we think there's a reason they're hanging out together, right? Because high-risk guys want to have sex with other high-risk guys or something like that. I'm using the term guys gender neutrally, of course. But I think there's something interesting that goes on with social learning. And I think one important implication of social learning is it's possible that you're going to get this geographic clustering of high-risk types and geographic clustering of low-risk types, even without some sort of a specific type, for all types of diseases, not just diseases like STDs, where there's high-risk activity that's important. That is to say, there's a natural inclination for high-risk guys to come together independent of the disease. And how does this work? I think it works something like this. Just to explain it intuitively without much math. And the idea is, imagine if there's a community around this part of the table and there's a community around that part of the table. We can imagine that if we're learning from each other and you think that the H1N1 is high risk or HIV is high risk or SARS is high risk, we talk amongst ourselves and we all agree, because we talk amongst ourselves, that it's high risk. And people at that corner of the table think it's low risk. It has nothing to do with the fact that I went to you because you're high risk. It just happens to be that you're my neighbor. We shared information. Therefore, we developed same beliefs about, or similar beliefs about the epidemic. That's going to affect our risk avoidance behavior. So we'll all behave. So if we think it's really high risk, we'll behave very conservatively with respect to the risk. We'll avoid the risk a lot. If you guys think it's low risk over there, you guys will all say, I don't really care. I can go to public spaces. I can go and interact and send my kids to school, even with a cough or a cold. Or symptoms of a cough or cold. And so what that means is the social learning is going to generate spatial correlations in risk behavior that can cause the disease to be worse than it otherwise would be if there weren't any social learning. So in effect, social learning can mimic can create the spatial correlations, just like with STDs, that worsen disease. And so I'm really interested. Yes, please. Oh, and by the way, ask questions in the middle. That's what I'm used to, as opposed to at the end.
You're kind of saying that attitudes are like infections.
I'm saying I don't want to use the word attitudes. All I know, the only thing I'm talking about right now is just information. Information then affects my beliefs about the risk and my behavior. You may call that attitude. I just want to be very clear about. I don't know what the definition of attitude is, but if that's what you define an attitude as, I agree with you. Yeah. So just the fact of talking to your peers creates these correlations. And I think that that's an important point that may not be as well known in the literature. Yes?
There has to be some factor that determines whether your peers are likely to agree with you.
Yeah.
What's the effect of media? What's the effect of...
No. I completely agree. And this is the standard approach that economists take. This is a all other things equal type analysis, which is to say, I'm going to go to CNN.com. I'm going to talk to my pediatrician. I'm going to read some textbooks. But in addition to that, I may be talking to my peers. And so, conditional on everything else being as is, I know that the fact that I talk to my peers will generate some local correlations. And let me give you another example in case you're not convinced, where you think this might actually be serious. So in another research project now, I'm looking at MMR, so the use of uptake of MMR vaccination in response to, so there's a lot of geographic variation in, I think, MMR uptake. So there are some communities where it's very high and some communities where it's low. And one of the things that I want to figure out is why it is that there's this substantial variation and how much of that is explained just by the fact that there's some people within a community that are really concerned about autism, talk to other people in the community, and therefore suppress vaccination uptake rates. In other areas where that's not the concern, vaccination uptake rates are higher. One of the concerns with that is that then you've got these small communities where if measles could survive, it's not as big a problem in developed countries as developing countries, then you could have measles epidemic that emerges later within that small subgroup. So you might imagine that this is a little bit more of a salient problem with respect to the autism vaccination link. But I think it's going to be relevant here as well. So anyway, so the two basic punchlines. I think people seek out information during new epidemics because there's very little objective information, and they seek that information out from their peers. And the second thing is that could affect the development of the disease. Now, I'd like to study H1N1 because I think that's what we're really concerned about today. But we don't have a lot of data on H1N1. We're just getting that stuff in. In particular, we We need data both on the prevalence of the disease, which we're just getting information on, and on how people respond, which we are far away from getting evidence on. So instead, what I look at is the spread of SARS in Taiwan in 2003. It's long enough since the disease that we can look back and see what exactly happened. And not only that, we have one country that does a great job of documenting individual behavior during the disease, and that happens to be Taiwan, which has this fantastic data set. So they've got universal coverage, health insurance coverage, but one byproduct of this is that they have this amazing data set that so it's got about 22 to 23 million people over the last 2 decades, and it takes 1 million of those people, and it tracks their day-to-day healthcare utilization and decision making. So we have access to that data. And so that might be able to shed some light on what happens during SARS. But before I go into that, let me tell you a little bit about SARS. A lot of this stuff is stuff that you're going to know better than me, I imagine, as I'm not a physician. But so what's SARS? So SARS is it's a viral infection caused by a coronavirus that looks like a flu, but then develops into severe pneumonia. You get transmission through close contact. There's a certain amount of time that the virus incubates, 2 to 7 days, before you get symptoms, and then it's a person with symptoms that can spread the disease. This was a very serious disease. So it originates in Guangdong province in China in November 2002. At least that's what we think. And then it spreads dramatically. So it stays in, I would guess, China up until maybe March of 2003, mainland China till March 2003. Then it spreads to a number of countries at once. I think 7 countries initially, one of which was Taiwan. So Taiwan has its first outbreak in March, caused by some people that had come from China, from mainland China. But then it spreads dramatically. So although it only goes literally outside of China from March to July, it spreads. There are actual cases in 29 different countries. There are 8,000 confirmed cases. We actually thought there were way more cases. It's just this is after subsequent epidemiological studies have confirmed there are only about 8,000 confirmed cases. The case fatality rate's 9.6, which is pretty high. So that's 9.6% of people that have confirmed cases die. And the 29 countries is actually an underestimate. I mean, if you look at the number of countries that were concerned about SARS, it's much larger than 29. It's just in 29 you actually had cases, confirmed cases. Taiwan was one of the first countries affected. Taiwan's a small country. It's only about, like I said, about 22 million people around this time. It's about the size of Connecticut, so really, really small, right? We all know that it's an island nation. It actually has a small number of cases, although there was a lot of concern. 671 confirmed cases, probable cases according to the WHO. Only 346 that are confirmed. So that corresponds to a prevalence. I want to be very clear about not knowing what incidence and prevalence in this context is. So if you just take the total number of people that were at the end assessed with probable cases and then divide by the population, you get a prevalence incidence rate. Let's just call it prevalence for short, of 3 out of 100,000. So it's not very common. That's going to be important because you're going to be surprised by the response that you saw in the population. So there's only 346 people that are ultimately confirmed. There are 37 deaths. That's less than half a day of road traffic. 11% is your case fatality rate, so that's pretty significant. Here's your first sense of how serious people took it, right? 150,000 people were quarantined in Taiwan, typically about 7 to 10 days. There are 2 categories of quarantine. There are Category A, Category B. Category A were people that go to the doctor's office with symptoms that might be SARS. You get put into quarantine. That's a more confined quarantine, very often at hospitals. You have Level B quarantines. Level B quarantines are typically travelers coming in from outside of Taiwan. Those people were placed in quarantines as well, but they were more loose in the sense that you could travel a little bit locally. You just had to report where you were at all times. So you could actually technically go to the hospital, for example. And within this 150,000, you do have a higher rate of incidence, about 45 reported cases. So this isn't a completely irrational quarantine. It's a rational quarantine. But it's not going to explain what you'll see. Well, actually, before I tell you the big response, this just gives you a time path of the infection. The x-axis here is going to plot the weeks in a year in 2003, so week 1 all the way to week 52. This is the number of cases. And I'm going to give you reported cases and probable cases. As you know, with epidemics, we don't know the answers right away. What we have is people that come in that look like they might have the symptoms. That might be a reported case, reported in this context being, well, it's a classification that Taiwan used, and it would show up in the newspaper that there were this many reported cases. It took two to 3 days for that to become a probable case, where we ruled out other things that weren't pneumonia or just kind of other severe illnesses, other severe respiratory illnesses, but not probably SARS. These are not confirmed cases, which are much smaller, about half as many as the reported cases. The confirmed cases take about a week to confirm, and even after that, there's subsequent adjustment to those rates well after the SARS epidemic is over. So I think when the SARS epidemic was over, we're looking at something around 600 people. And then, like I said, that got down to 346. So this is what it looks like. So what you're seeing is in March, you get this initial outbreak. The initial outbreak is because of people coming in from China that are quarantined with the infection in a Taipei hospital. It stays within travelers, but after a few weeks, you have actually something called the Hoping Hospital outbreak, which is an outbreak among people that are Taiwanese. And then once that occurs and that's reported, you're going to see a big response on the next slide, but then you start seeing a massive increase in the infection rate within Taiwan. But by July, the disease is gone. Okay, actual cases are gone. Now, how did people respond to this? Well, not surprisingly, people avoided public space. You caught it from somebody else. You wanted to stay away from other people. So the main response that people had was that they avoided public spaces. There's a May 2003 survey right in the heart of the epidemic that asked people exactly what they did. There's the standard answers, hand washing, things like that. But the big response was, I want to stay away from any public spaces. That survey didn't specifically ask what specific public spaces, but we know that people also stayed away from medical visits, and there are a number of reasons why. I think the most important reason is because almost all the transmissions that occurred in the hospital setting. So people thought, well, yes, it's good to get care, but I'm very likely to actually get infected there, so I should stay away. The other thing is that there's no sense that doctors could cure SARS. It was still unknown. Everybody was still trying to figure. It wasn't until April of that year that China knew that SARS was that the SARS virus was a coronavirus. Didn't share that information with the world until April, and so it took a few weeks after that before the WHO figured it out, and it took some months after that for the world to figure out what to do about SARS, which is largely quarantining. So there's no sense that people could cure it. Newspapers didn't say, oh, your doctor's going to give you a pill and cure it. So it wasn't that people were going to the doctor in order to cure themselves with SARS. And they might be going to the doctor to diagnose themselves with SARS, but one of the interesting things is the thing that's going to fall the most, people are going to stay away. The people that are going to stay away are the people that have respiratory illnesses. So it's kind of perplexing. You would think that if you had a respiratory illness and you would go to the doctor, in fact, you stayed away. There's one concern that people might have been staying away for fear of quarantines. I'm not sure that's the case. It's plausible. The quarantines were short-lived, and as I'll explain, the Taiwanese don't they like the doctor. They go to the doctor a lot, and so it's not obvious that the mere fact of a quarantine is something that's going to keep them away. That's being a little simplistic about it. But the key thing here is that even if you don't buy, even if you're skeptical that people might avoid the doctor in response to SARS, you still have to explain that there's this massive 25% drop in medical visits during this period. So one thing I forgot to tell you is that I break down the SARS period into 3 parts. The first is this initial outbreak where it was just the people coming in from China that were having it. Then there's the big part of the meat of the epidemic in Taiwan. So this is called SARS period 2. Okay, roughly goes from week 16 to about week 24. And then there's the third period where it dies out. And about halfway through the third period, it's completely gone. It's just empty. So now let me show you this graph. Same SARS periods, weeks 1 through 52. The blue line is going to tell you visits in 2002, just as a benchmark for what people would have done in the absence of SARS. And then the red line is going to tell you the visits in 2003, which is during SARS. A few other small things. This is I'm going to count this off in millions of visits. So we're looking at, visits were around 6 million to start off with. okay, per week. And then I need to explain these spikes. Anybody want to take a guess at what these are? Huh? Close. They are Chinese New Year. And it changes each year, which is why the spikes are at different times. Okay? So we don't want to worry about that. Everything shuts down in Taiwan during Chinese New Year. So you resume back here. During SARS period 1, when you have the first outbreak, there's no response in visits, right? They think, oh, these are just some visitors coming in that are sick. SARS period 2, which is when you start having both the domestic outbreak, the Hoping Hospital, and you have massive increase in reports in the newspaper. And by the way, every day the newspaper would report on the lower right-hand corner, here are the number of reported cases, here are the number of probable cases. Okay? It's like a daily tally. And in your local version, I mean, this is a small country, but you would get a local version, and the local version would indicate in your township how many there are. Okay, so people constantly got what I'll later call this public signal about what the prevalence rates or incidence rates were. Then you see this massive drop of 25%. Okay, so you go from 6 million visits to 4 million visits. That's remarkable. Right? Where incidence rates were 3 in 100,000, death rates were 1/10 of that. It's like, if I told you there were some car accidents on Lakeshore Drive, everybody stopped driving. That sort of response. So this is a very big deal. This is, and I don't want to. It is a very big deal. I don't want to overstate it and say, people with heart attacks stayed home. No, obviously, if you had a heart attack, you went to the hospital. If you broke your bones, you went to the hospital. A lot of this is people with respiratory illnesses staying home. But there's a lot of, there's a whole range of diagnoses that are staying home now. Potential diagnoses. Okay, so one thing you should notice is a huge drop. Second thing you should notice is how long that drop continues. The disease ends, in terms of actual cases, in the middle of SARS period 3. But how long does it take for visits to return? It takes to the end of SARS period 3. So you're done with the SARS epidemic in an objective sense in July 11th. Your epidemics your visits do not recover until September 23rd. That's a long time, right? So it's this persistence of the suppression that we want to explain. That's very interesting. I'll give you something else. It's not just persistence over time. Let's take a look at townships where there were no SARS cases. None at all. Never were at any time during the epidemic. Same sort of thing. Of course, the number of visits are smaller. These are further away from Taipei, right? And you have lower prevalence of doctors further away you go, lower density of doctors. So you're going from 1.2 million visits, okay, to basically 0.9 visits. And again, you get this massive dip. So you're up here, and you fall down to here, and this is in the 0 township visits. So this is not something that's confined to places that have a lot of epidemics. So that's kind of interesting. So here are our puzzles. One is the large drop. The second is the sustained drop after the end of the epidemic. It's particularly in the drop in the 0 case townships, or what I'm calling 0 case townships. And then here's another thing I haven't told you yet. Not everybody responds the same. Okay? So you would think, fine, I mean, it's one thing to say everybody, if I condition a township on the number of cases, so if they take 10 townships where there's just one case per 100,000 in those 10 townships, do they all respond the same? And the answer is no. They do not respond the same. In fact, one township may have a 30% drop in visits, the other might have a 2% drop in visits, even though they have the same SARS prevalence rates. And let me give you a graph that indicates that. I'm going to call this the excess variation graph. And so here's what I did. I said, let's take a look at so I'm looking at different doctors' offices, and I'm saying within a township, all the different doctors' offices are going to have the same information about what SARS prevalence is in that township. And I just want to see how the different doctors' offices, the patients of those different doctors' offices respond. So I'm holding constant, in some sense, people's information about the prevalence, and I'm seeing, are there some doctors where there's a massive reduction in visits and some doctors where there's a little bit of reduction in visits, okay? And I compute what's called the coefficient of variation. So I take the standard deviation and I divide by the mean. And if anybody's interested, I can explain why I use coefficient of variation rather than straight variation. And I say, okay, how does that change? Yeah?
In layperson's terms, is this basically more than you would expect just by random variation?
That's why I put the blue line up. Okay. Exactly that. So first I want to say, in every one of these, by the way, you should always be paying attention to the baseline being the blue line. The blue line is 2002. There's nothing interesting happening in 2002. And nobody anticipated SARS happening in 2003. So it's a good thing to look at. So here's your variation, your coefficient of variation in 2002. Yeah, there's some movement around. That's not surprising, but nothing big. 2003, massive increase in how different hospitals respond, different doctors' offices respond. So I'm thinking about groups of patients with similar information. That's at the township level, because that's the level at which you get information about SARS in the newspaper. And then I'm just looking to see how different patient groups, as defined by the doctor they go to, they respond. That's what this variation is telling you. Okay?
Why is there so much variation for New Year's?
So part of that is mechanical. So you're basically asking me, why am I looking at coefficient of variation rather than variation? And that result is going to be explained by this change. So here's the problem with looking just at variation. What is the minimum number of visits that you can go to? 0. Okay? So what happens during SARS? Visits decline. Now, as you move towards that 0, as visits decline, variation mechanically has to be compressed. That's just a function of the 0 bound. So if you look just purely at variation, you get this artificial suppression that would occur. Okay? So variation for things that have a bound is not a good measure. Right? Variation only works when you're not restricted in that way. So a standard response to that is to say, when I have this problem, I'm going to divide by the mean. I'm going to look at my coefficient of variation to adjust, kind of make it proportional. What is the proportional reduction or change in variation proportion to the level? Now, that seems to get you a bias in the other direction, because if the mean declines, then the coefficient of variation, which is your standard deviation of the mean, should rise. So that should artificially push you up, right? That's something to be concerned about. Well, one of the nice things about the Chinese New Year is that we have a mechanism to figure out, our baseline to figure out whether or not that's what's driving this result. We know that visits are declining here. Could that be the thing, just the visit decline and not the variation that's pushing this up? Well, we could just see what happens with Chinese New Year. In Chinese New Year, as it turns out, visits, so this is 0 township, this is prevalence response. You see that the visits fall much more during Chinese New Year than they do during SARS, because everything literally shuts down. So if it was just a mechanical increase, we would expect these to have a higher coefficient of variation. But if it wasn't mechanical, if we really think it's something deep going on, then we'd expect it to have a lower one. And what do we find? In fact, the coefficient of whoops, that's 0. One more. The increase here is not as high as the increase in the peak here, even though the mean is much higher here. So we're pretty convinced that this is, I'm pointing to the right thing, this is something deep about the variation. Yeah?
Maybe I missed it, but the newspapers or TV, were they recommending people to stay home and only go to the hospital if they have
yes.
this type of symptoms?
Yes.
Like fever? That's one question. And the other, did people have to pay to go to the doctor?
Yes, so it's national health insurance, but the copay is very low.
When you were looking at the variation of different type of doctors, did they have like different type of insurance?
No. So this is why Taiwan's perfect. Not in a deep sense of, I'm not endorsing any particular health reform, but what I'm saying, Taiwan's perfect to study because everybody is insured by the federal, I want to say federal, but I mean the national health insurance. Everybody has the same copays for every, so a little bit about healthcare in Taiwan. First, the Taiwanese love going to the doctor. They go to the doctor about 10 to 12 times a year on average. They go to the doctor, that's a lot, okay? And they have what are called local clinics, and then they have hospitals. The local clinics are a little bit different than our local clinics. They're a little bit more like CVS clinics, where you just walk in and you can get paid. You don't have to have long. You don't have 3-month ahead appointments. They have different copays for hospitals and for doctor's offices. That's not surprising for clinics. And it's very low. It's the equivalent of $2 is your copay for going to the doctor. Okay? And I think the copay for going to the hospital, I'm translating to American dollars. It's higher in Taiwanese dollars. I think it's something around $10 or $12, the copay for a hospital visit. So this is not, and it's not a poor country. So this is not a huge difference. This is not a huge hindrance to going. And one of the nice things is because everybody's paying the same price, we can actually compare different facilities within a township, different townships, all these things. So again, an ideal setting for us to study. Okay. So I hopefully have convinced you that there are these three very interesting things that are going on that we'd like to study. So the three are the large drop, the drop even when there are no cases, and the sustained drop, and the excess variation. Okay. Again, this is what interesting features that we observe in response to a new epidemic. Now, it's true that we don't think the response to all epidemics is going to be avoid the doctor. Okay? So the hidden assumption I'm making is that we can learn a little bit from Taiwan, even though the prevalence response might be different, might be the exact opposite with respect to H1N1, insofar as I think that the reason, the mechanics of the prevalence response is going to be the same, in the sense that the way people learn about the disease, things like that. What they ultimately do to avoid it is going to be not relevant to the behaviors that I'm seeing. That's the hidden assumption, you see? Everybody get that? Okay, great. So what is it that I want to explain? I want to take a look at that picture that has the decline in visits and the extended decline and the variance. And I want to say how much of this can just be explained by people trying to avoid the risk of death, right? If it becomes more, if I tell you it's more risky to drive on Lakeshore Drive, you're going to avoid Lakeshore Drive, even if you're not risk averse, even if you're risk neutral, just because basically the price of driving on Lakeshore Drive is increased. Just like here, if there's a greater risk that you're going to die when you go to the doctor, even if you're not risk, even if you're a gambler, you'll say, I want to stay away from the doctor's office. It's like the copay has gone up. So pure risk. I'm an economist, so that seems like a very natural statement to me. So the value of the doctor's visit, so the implicit copay from visiting the doctor is increased. Another concern is that I'm a little bit risk averse. Right? It's not, I would respond differently to let's suppose the copay was $2 and it went up to $2.05, which, by the way, is about how much, if you were a risk neutral person, the SARS epidemic would be worth. About 5 cents increase in your copay. I'd want to say, well, but it's a risk, right? It's not merely that the copay went up from $2 to $2.05. It's that 5 cents is, it could be an infinite cost because I could die, or it could be nothing at all. I know, except in 3 cases out of 100,000, there's no cost at all, but it's that risk that I care about. So risk aversion could explain it. Another thing that economists are now more and more concerned about is this idea of ambiguity. Even if you told me exactly what the risks are, that would be risk aversion. But let's suppose I didn't know what the risks are. Okay, there's just uncertainty. It could be 1 out of 100,000 chance, it could be 3, could be 8. I just don't know. I know the mean is 3, but I don't know what the exact. I couldn't give you a 95% confidence interval if my life depended on it, and it might. Just that ambiguity might scare me a little bit. I'd like to know more information. And so maybe that's a reason I'm staying away, and that's explaining this drop. And one of the reasons why I like this is because even after the visits end, after the epidemic ends in July, people might still be unsure, is it really over? And that uncertainty, even if I think that the probability of getting it is 0, the fact that there could be a positive probability, right? Maybe that's uncertainty, and that could keep me away. Now, whether you think it's risk aversion or ambiguity, those sorts of things are going to get you to want to get more information to make sure you got those risks right, or you reduce your ambiguity. And so I want to figure out how it is that people learned about the SARS risk, and how much information do they get from the media, newspapers, TV, but also how much did they get from social learning? How much did they just get from their peers? Because I think that's going to be critical for explaining, for example, the excess variation, why different doctors' offices had different levels of visits even though they're in the same township with the same prevalence risk. Okay? Just because, you all have played the experiment, or at least your kids have, in school where you sit around a table, I tell you something, you tell that person. By the time it gets it's something completely different, right? So you can imagine if we did this over two different tables would get two different results. Just like that, you can have, just through social learning, a lot of differences in beliefs about an epidemic, even starting with the same initial piece of information. So social learning might explain some of that. And then at the end of the day, I'd like to look at what the welfare effects of this are. And what I mean by welfare effects is, is society better off, worse off with these things? So here's the first thing. Actually, prevalence response is a great thing, because at least in this, because it's keeping people away from public places, which suppresses the disease. Right? And in fact, one might say that it was this great reduction in visits that really contributed to the control of the epidemic. And to the extent that risk aversion or ambiguity aversion causes people to be more prevalent response in some sense, stay away, that's a good thing, not a bad thing. But we'd really want to know what's the effect of learning. Learning may have the opposite effect. If I get more learning, I may be less concerned about ambiguity and more likely to go. So social learning can have a double whammy effect. Not only that effect that I talked about before where you get spatial correlations, but it could also make people less concerned, right, less ambiguously averse or averse to ambiguity because there's less ambiguity, and therefore they don't avoid the epidemic as much. Okay. So let's just get a sense of what my time is. Okay. So I'm going to skip this connection to ambiguity for a second because I think that's a little bit more detailed. I want to give you social learning. I want to focus on social learning because I think that's the only thing I've got data today that I can tell you. I really think there was a lot of social learning going on, and I can say that with confidence. So there are two problems with proving their social learning for an economist. So why do I say for an economist? Because there are more bold departments at the university that actually go and talk to people. And economists don't like to talk to people. We're awkward, we're socially awkward, we don't dress well, we don't shower all the time. These sorts of things make it so that we don't actually get truthful responses. So what we do is we look at numbers, we look at data. And we sometimes use the excuse that, well, if I were thinking about it in 2003, I might have interviewed somebody, but now here I am in 2009, I don't have that opportunity, so I'm just going to look at data. So I'm going to use that excuse. So we're going to want to look at data, right, numbers, and infer something about behavior back in 2003. Now, what behavior do we want to infer something about? We want to infer something about the conversations that you two, what's your name?
Hikmat.
Huh?
Hikmat.
Hikmat's? Hikmat. And what's yours?
Sarah.
Sarah and Hikmat. I want to know the conversation these two had. Let's assume you were in Taiwan in 2003. What conversation you had? Now, I don't observe that conversation. Okay? Instead, what I observe is your health consumption behavior. Whether you went to the doctor, what you did in 2002, 2001, etc., and what you did in 2003. So I'm going to I'm going to try to figure out, I'm grasping at straws here to some extent, right? But here's the argument. I can't observe what you said to her, but I can observe how you changed your behavior relative to 2002. So how much you went to the doctor less in 2003 relative to 2002. And I can see what you did in 2003 relative to 2002. And I know one thing. If you had some sense of what the risk of SARS was, and Sarah came to you and asked you, you would then share that information. You'd have the same information you'd have beliefs about the SARS risk. But that also means that since you're going to decide whether to visit the doctor on the basis of that beliefs about the risk, that the change in your visits to reflect your believed SARS risk is going to be similar to the change in her visits to reflect that SARS risk. So I don't observe the conversation, but I observe the visit response that is caused by the conversation, and then I can see if your visit response is correlated with her visit response. Okay?
Not the same way that they call it flock.
Yes,
That
I think.
sheep follow the...
Yes, exactly. Now, but here's the problem with using this. There are two, right? One was this: I don't observe the actual conversation. Instead, I have to look at your behavior to infer something. That's going to be the first problem. What is my proxy for people's beliefs? And the second problem is going to be, well, how do I know that it was the fact that you guys shared the information that meant that you behaved similarly? Maybe you independently arrived at the same result. Like you both read the same, TaiwanCNN.com story, and therefore you came to the same belief. And so it looks like you're doing the same thing, but it's because you've got that information from a third party, not from each other. So those are the two effects. The first effect is I need a proxy for beliefs. when I don't actually, I need a proxy for the conversation when I don't observe the conversation. And the second thing is I need to rule out what are called common unobservables, or the reflection problem. You're behaving similarly because you both observe something common, not that you talk to each other.
So when you talk about social learning, are you specifically talking about that conversation, or are you talking about the whole social culture that would go around us reading the same article, as opposed to, right, we both went to CNN.com rather than going to Fox News?
Yeah, so as it turns out, either one of those things are going to cause the spatial correlation that I'm concerned about with respect to the development of an epidemic.
Right.
But here I'm actually going to be concerned about you talking to each other, not merely both having read the same CNN.com story. Okay. I want to make it in this particular way because I think that that's the hardest thing to identify. Now, one thing that I think is perfectly plausible and that I cannot rule out is the following. That we're all in the same township, you go to your doctor, you go to your doctor, but you get the information from your doctor rather than from each other. So you may have a different response than you guys have because the doctors came up with different opinions despite the fact that everybody's in the same township and has the same prevalence risk, right? That's possible. I can't rule that out. And that's a little bit closer to the kind of story, you're all reading the same CNN story. Well, actually, as it turns out, you're talking to the same doctor because you're in one doctor group and you're going to see a doctor in another practice. Okay? So let me tell you a little bit about how I'm going to identify peer effects. So those two questions: how do I identify people's beliefs, and then how do I rule out what are called common unobservables? Okay. So it's very hard, very, very hard for an economist to give a talk without putting some math on the board, some algebra. So I just have to give in. So one way to think about this, and I'm going to do this without actually, I'm going to do it with a graph instead of algebra. So everybody at some point, probably involuntarily, have seen supply-demand graphs, right? So here on this, on the x-axis, you're going to get visits to the doctor, or visits to the hospital, right, quantity, and here you're going to get price. Okay, as the price of visits rises, you're going to go less. And so you've got this demand curve pre-SARS that says if the price is really high, I'm going to visit very little. If the price is really low, I'm going to visit a lot. As it turns out, Taiwan has a copay. Everybody faces the same price, called C, the copay. So what do I know? I know that before SARS, I look at the intersection of the supply curve and the demand curve to give me the quantity of visits. The quantity of visits before SARS was right here. All of a sudden, SARS hits. And in the Q&A, if you're interested, I'll explain more detail about this. But SARS operates kind of like a tax, right? You're getting the same health care when you go to the hospital, except you're also getting this added benefit of a risk of dying. Okay? Well, that's not a good thing. That's a bad thing. So I can translate that into functionally a tax, and that tax is going to be linearly proportional to Q, where Q I'm calling the probability of getting SARS. So whatever you think the probability of getting SARS is, you're going to pay a tax that's roughly proportional to that. So instead of thinking that you're facing a price C, which is the copay, you think you're facing the price C plus an implicit health tax. So the price that you're thinking about, right, that you really think you're paying for going to the doctor is up here. Well, when that intersects the demand curve, you're going to get a lower level of quantity demanded in equilibrium. That's what you're going to see. So you're going to see the total number of visits shift from here, where we thought the copay was just a copay, to here, where we thought, well, you pay the copay plus the SARS tax. Okay? And I'm going to say I can observe this change. That's what the investigator, can observe. And I'm going to say this is proportional to people's beliefs about the risk of SARS. That's why I think I can look at visits and infer something, change in visits, not just the level of visits, the change in visits, and infer something about people's beliefs about the risk of SARS. Okay? So I've got some proxy for your beliefs, and now I've got some proxy for your beliefs. What do I do next? I want to try to correlate those two. Okay? So what am I going to correlate them to? I'm going to correlate them to each other, but I need to rule out common observables. Now one thing I need to stop before I tell you about common unobservables, I need to tell you what I mean by a peer group. I've kind of implicitly just kind of tossed it out there already, which is I'm thinking that a peer group is all the patients that go to a particular doctor at a particular facility. Now that's not natural. Right? Most people think a peer group are the people that live on my block, right? The friends I develop at work, people I went to school with, or college with, or whatever, right? Those are my kids' friends. As it turns out for me now, it's just the parents of my kids' friends. They're much better at making friends than I am. But those sorts of things. But here, I don't have information on those specific peers, but I know all the people that went to a particular doctor at a particular office. And one of the reasons why I think that that's a reasonable peer group is because these are extremely local practices. So there's probably a substantial overlap between the people that are going to a particular doctor and the people that live in a particular neighborhood. Okay, so that's why I'm going to look at this. And not only that, I'm going to define those peer groups, just to be careful. I'm going to define them back in 1999 and 2000 to make sure that the peer groups are not changing during the epidemic. Right? I just want to fix them. So that's what I'm going to define as a peer group. And by the way, I mean, if you're going to the hospital, doctor or hospital 10 to 12 times a year, you may have many peer groups. So I allow for that. So I'm going to look at people's responses to different peer groups. Each person on average in Taiwan has 6 different doctors that they go to. Yeah, these guys go a lot. I mean, if your copay was $2, you might go a lot too. Okay, so now how do I deal with this issue of common unobservables, which is the real problem here? And in order to explain this, let me explain exactly what it is that I'm going to use as my proxy for what your peers believe. So you're the index patient. You want to figure out what your peers are. Your peers are the people that go to the same doctor and the same office. And what is my proxy for their beliefs? The change in their average visit rate from last year to this year. Right? It's just like the change in your visits from one year to the next. Right? You guys were peers. I'm just taking all the people that are like you from Sarah's perspective. All the other patients that are in the hospital. They go to the same practice. Got it? So how do I control for other common unobservables? The first and most important way is that I say, I'm actually going to control for just the level of visits that everybody else in your peer group is making to the hospital. Not the change, the level. Why is that important? Let's suppose the doctor decides to just shut down the office for a day. That's not going to affect the I mean, it'll affect the change, but the main effect it's going to have is just on the level of visits. Okay? That's not what I want to measure. I don't want to measure the doctor's closing down the office. I might want to measure the doctor telling you about the risk, but I don't want the doctor to, I don't want to measure just the level. So if I control for the level of visits, then I'm going to control for that kind of what's called a common supply shock. I also want to control for the information that you might have elsewhere about the risk, right? That might be a reason why you're behaving. So let's look at the newspaper, see what the report was for the local number of reported cases or probable cases or confirmed cases, control for that. So I control for SARS incidence and prevalence as reported in the newspaper. Here's an important thing that I think I control for that makes a big difference. So as it turns out, you may learn from your peers about lots of things, about how long waiting lines are at the clinic, how good the doctor is. You may do that even before SARS. Okay, what I'm really interested in is how much you do that more during SARS. So let me interact my treatment with whether or not it's in the SARS period, right? Starting in March, going through September. Do you have more reliance or greater reliance? Is there a greater positive correlation between your change in visit behavior during SARS than before SARS? Okay? Again, another way that I control for common unobservables. And then I have other small technical stuff that's not that important. But I'm going to try to convince you that I'm going to try to control for as many other outside influences so that I can just isolate what the effect of social learning is, the correlation that's local. Yes?
Help me understand the data, the individual level data?
Yes.
Over time, and you've linked?
Yes. It's a full panel. Yeah, and we have lots of information about these people. I'm just going to happen to look at their visits, but I can break it down by what their diagnoses were, everything. Okay. All right. Like I said, there are some places where I just have to put some algebra on the board. So basically, I'm going to regress at Sarah's visits on the change in her peers' behavior, just generally, the change in her peers' behavior, particularly during the SARS epidemic. That's going to be the change in the peers' behavior interacted with the SARS period. Then I'm going to look at levels, same sort of thing. We're going to look at SARS cases, and then a whole bunch of other stuff. Okay? And I can go through some of this other stuff. But here's my main prediction. I think Sarah's behavior is going to be correlated with her peers' behavior. So the change in her peers' behavior should have a positive effect on her visit behavior. That's the key thing. That tells me that there's social learning going on. And then I want to quantify that. Okay. So If you're interested, I can tell you summary statistics, but I want to get to Q&A. So let me give you some of the basic results and some robustness tests. So do we get this answer? Do we find that, in fact, for example, people are stay away from reported SARS cases, but they are positively correlated with their peers' visit behavior? And you do. And that number is larger during SARS. So before SARS, first row, you're finding a positive correlation, and it's can be significant. Here what I've done is I basically just looked at different levels of controls. Here I've run the regression, and I said I'm not going to control for anything. I'm just going to correlate Sarah's visits with the change in the visits of her peers. Here I said, no, let's control for the level of her visits of her peers. And here I've said, let's also control for the SARS cases. So I'm gradually introducing controls to eliminate these common unobservables. So you really want to start with this column right here. This column tells you, yeah, there's some positive but insignificant correlation between Sarah's behavior and her peers' behavior before SARS. But once you get to the SARS period, you get a very significant increase in the correlation between her behavior and her peers' behavior. The coefficient is 0.068. You're not going to be able to interpret that yet. I'll do that on the next screen. Because there's no, what does that mean, that your visits are correlated 0.06? But the key thing is that you're getting this significant result, and it's persistent. It falls as you control for common observables, but it stays around this 0.06, 0.05 level. Okay? And there are lots of controls in these regressions. This is a fairly intricate setting. And the reason why I go and keep on adding stuff is just so that you know I can get it in the raw data, or something close to the raw data, and with really kind of granular data. So what's the interpretation? What do we make of that number 0.068? Okay? Well, here's a little thought experiment. Now, in order to explain the thought experiment, let me first say one more thing. When I look at the change in other people's behaviors, it sometimes takes time between when you have the conversation with your peer to when you've actually changed your visit behavior. And the reason is because you're not going to the doctor every week. Sometimes it might be that you're going to go to the doctor 3 weeks later, right? And then your past conversation is going to affect. So what we do is we actually say, what is the effect of Sarah's visits today or this week based upon our conversations or the change in other people's behaviors last week, 2 weeks ago, 3 weeks ago, 4 weeks ago.
How do you determine the lag?
We don't. We let the data determine it. So we include all these lags. We go through, in this here, we're talking about lags that go up to 4 weeks, but we've done it to 8 weeks and 12 weeks. 12 weeks are a little bit problematic because then you really have the stretch. But you can do 8 weeks. I'm going to show you 4. But here's the yes?
But to that question, does that reflect that the interval is longer ambiguity, or does that shed any light on what your findings are at the end? I would think the longer the interval, that would be significant. And so even if you have it as a determinant, there has to be some quantitative information there.
Yeah, so we're exploring that now. I'm going to show you the time path of that correlation. And as it turns out, the time path of that correlation has it peaking around 4 weeks to 5 weeks after the lag, and then it declines. Now, how to interpret that? There are many different ways. One way to interpret that is that it just takes some time to absorb the information. Okay? Not only does Sarah get the information from peers, but then she has to think about it for a little while. Another way is to say, Sarah might update her beliefs right away, but she doesn't have to go to the hospital or the doctor that week. It could be a few weeks. The median, not the modal, the median time between visits for a Taiwanese citizen is about 3 weeks. Okay? So it could be that the lag is explained by that. Another way to explain is that it's just that you're continuously building up information. At some point, you feel comfortable acting on that information. All these are plausible explanations. I don't know of a way to distinguish between these things. They're all consistent with I learned from my peers. But if you want to break down that black box even further, right, open it up, that's a little bit harder. I can describe it empirically, but I cannot tell you. And that part of that is, even if I'd observed the conversation between these two, I wouldn't be able to figure out what's going on inside Sarah's head in terms of how she's processing that information. Right? I'm proud to say even an anthropologist might not be able to figure that out, or a sociologist who likes talking to people. Okay, so let's play our thought experiment out. So let's suppose that I were to say that I were to reduce, increase Sarah's peers' beliefs about the risk of catching SARS by 1%. So their beliefs had increased by 1%. That would show up in my data as something like, over the last few weeks, their visits had increased by 1%. Why? Because their visits are proportional to their belief about the SARS risk. right? Because it operates like a tax. So I say, what is the effect of that 1% increase in her in her peers' assessments of the risk of SARS on Sarah's visit response? Now, it's going to turn out that it's not just going to affect Sarah's response in 1 week. It's going to affect Sarah's response for multiple weeks because she's going to live with that knowledge, right? And so she might reduce her visits this week, the next week, and so on and so forth. So I want to say, what is the kind of the permanent effect on the decline in her visits or in the increase in her visits? Here it's going to be decline. 1% increase in people's peers' beliefs. What is the decline in her visits? I'm going to look at an interval of 5 weeks. So what I'm going to ask is increase the beliefs about the risk of peers by 1%. What is the decline in the number of visits over the following 5 weeks? And I want to put it in some sort of metric that you understand. So I'm going to say, let's just suppose we take that decline in visits over the next 5 weeks and all allocate it to 1 week. So how much of a decline in a 1 week visit would you see? Does that make sense? So the percentage change, what is the equivalent percentage change in 1 week's worth of visits? Okay, it just gets hard because there's a diffuse effect over time, right? You keep those beliefs. And so what do you find? A 1% increase in Sarah's peers' beliefs decrease her visits by 0.05%. Okay? Now you might say, okay, that's great. Now you've expressed it in percentages. I understand percentages, but is that a big percentage or is that a small percentage? And here's a way to index that. Let's take a look at, for example, how she responds to the level of other people's visits. What might that reflect? That might reflect something like either a supply shock, or it might reflect the probability of meeting somebody else at the hospital's office, at the doctor's office. So if we look at the effect of pure levels, right, which are going to measure other types of common unobservables, we find elasticity instead of 0.05%, so 1% has a 0.05% effect. You find something that's 0.11, so roughly double. Roughly double. So a supply shock will have roughly double the effect as just talking to her peers. Doctor shutting down the office is going to have double the effect, but only double the effect of talking to her peers. That's big, I think. If you really want to be convinced that it might be a big thing, let's suppose that I increase the number of SARS cases reported in the newspaper by 1%. Okay? How much would that decrease Sarah's visits? Sorry to pick on Sarah, but 0.007%. Roughly an order of magnitude less. So she's less responsive to a 1% change in the newspaper report, which is quasi-objective, than she is to what her peers are thinking. Okay, so you might think that Sarah is a neo-Burkean. She doesn't change her beliefs, but to the extent she does, she changes it a lot more in response to her peers than she does to what the newspaper is saying. Okay. Yeah.
I'm late, but one of your slides said township or community. So tell me the proximity to the peers. Maybe I missed that.
So a township.
What's the neighborhood or the community that's being measured?
Right. So you have a township. Within the township, you have a bunch of doctors' offices. The doctors' offices are going to define the network, as opposed to your physical neighbor, like the person that lives next door to you or the next block. You're going to look at who all goes to the same local clinic. There are two reasons why we look at that. One is just practical. We don't know who's living next to each other. The data doesn't actually give us GPS information about exact address. The second reason is because clinics are very local in Taiwan. As I was explaining before, they're like your.
You say local. How local? How much
like
distance?
Going to your CVS. It's like a retail clinic, as opposed to going to the University of Chicago. The University of Chicago is going to draw people from all over the city. Your health clinics in Taiwan are not. They're going to be.
And how far apart are they roughly?
That I don't know.
But that would be such a huge determinant in this model, wouldn't it?
Well, so I'm going to give you some information that's going to suggest that there's some correlation as long as you're in the same so there are a bunch of clinics. So there's kind of a hierarchical structure to the way healthcare in a township works. So there's a township. Within that, you're going to have 1, 2, 3 hospitals. Taipei, you're going to have a lot more. Within that, you're going to have a set of clinics that are going to feed into that hospital. So if you happen to get sick at the clinic and you go to that hospital. So within this, we can say how correlated are people's behavior when you're just looking at people within a particular clinic. Then what is it within a particular hospital, getting fed from a bunch of clinics. And how does that change if you go to another hospitals? Now, but I do know, to the extent that markets play any role in this, you would imagine that there's going to be some level of dispersion. And there is going to be some concentration at the town center, just like there is in any town. But there are just standard boardwalk models will tell you that there's going to be some spatial differences so that they can market themselves to different groups. But I can't get any more findings. I just don't have that information. Okay. So now let me convince you. By the way, you should always feel free to jump in with questions. And we have till 1:30, right?
Yes.
Okay. So I'm going to give you some robustness tests and then open it up. So what I mean by robustness tests, I just want to check whether I'm right or whether I'm getting something spurious, right? So what are some things that I can do? Well, I've been comparing your visits in 2003 relative to your visits in 2002. I've taken a 1-year difference. And the reason I took a 1-year difference is because I assumed there might be some seasonality in your visits. Maybe you're visiting for allergies at one time a year, flu another time, whatever it happens to be. But maybe that's what's driving this. Maybe if I just took as a baseline for the change in visits of peers, some other point in time, I'd get a different answer. Let's say 6 months. We've done this for many different things, but I'm going to do 6 months. Now, it's got to be a long enough change that somebody at the end of the SARS period is not at the beginning of the SARS period, because that would be a strange change, because then I'm comparing SARS to SARS. I want to compare SARS to pre-SARS. So I look at 6 months, because the SARS period is not 6 months. And what happens to my coefficient? It goes from 0.068 to 0.061. Still statistically significant, quite significant, in fact. Standard error of 0.013. Okay? So that's not going to change things. So it's not my baseline that's doing things. What if I do something along the lines of what you were talking about? And this is just going to be the first slide on this, not the second. There's going to be a second. I want to know, average Taiwanese person is visiting 6 different doctor's offices. I want to know when, and let's count them from 1 to 6. Are my visits, Sarah's visits to 1, her first doctor, influenced by the peers that also go to that doctor, or by the peers that go to the other doctor she sees, 2 through 6? Okay? So what I did is I said, let's account for those separately. So I take the visits by peers to doctor 1, and then separately I count the visits of peers to doctors 2 through 6, and I say separately what is the influence of those 2 peer behaviors. If I look at just doctor 1, right, and her visits to doctor 1, the coefficient is high, 0.071. Before it was 0.068, statistically significant. If I look at the other networks that she's part of, other peer groups, you find a significant effect, but it's about half the size, 0.04. Okay? What does that tell me? If you're deciding whether to visit doctor number 1, you look at your peers that also visit doctor number 1. I don't know the answer to that. I'm all eyeballing it now, and the answer is probably no. And the reason is because 0.02 times 2 is going to get me to 0.08. Yeah, so they're not going to be. It's not going to be different. Okay. Now, no, it's not. But here's the one thing I do know: if I do this individually, these coefficients fall dramatically. That is to say, they're going to, so here I've just amalgamated all the information you have from other visits. If I look at each of the things, now that's a little bit difficult because people are going to have different numbers. So I'm going to have a lot of missing, so I drop off. So you want to be a little bit careful about that particular test. So you're going to get a little bit less. Now let me give you another thing. So maybe you're learning from that direct peer. I want to show you one other thing before I go back to those other slides. So what if I do something else? And this slide is intended to do 3 different things. One thing is to serve as what's called a falsification test. I'm saying that Sarah's visits are determined by the visits of her peers, roughly, right? What I want to figure out is if that's spurious. So let's suppose that I, instead of trying to correlate her visits with the visits of her peers, I correlate her visits with the visits of some random peer group that I've plucked out of Taiwan, or I've plucked from something else. So what it is, I plucked that random peer group from some other peer group in the nation. Then I've confined myself to another peer group in the county, and then another group in the township. And in fact, I did it also for hospital. And that's not reported here, but I'm going to tell you the coefficient, which gets at the earlier question a little bit. Okay? And I'm going to say, is there a correlation going on there? And if there is, I'm very worried. Okay? Because that means there's something spurious going on in what's going on. So that's the first thing that's going to be done here. The second thing I'm going to get is, it's not just spurious correlation, but you're going to get, so you want to be able to falsify. I actually strongly predict that her behavior is related to her peers, not some random other person. So that's the falsification part of it. The spurious part of it is if there's a significant effect and I know that I'm calculating my standard errors incorrectly and I'm overestimating the significance of my coefficients. A third issue is going to get at the issue of, well, am I, why are these clinics dispersed in such a way that I don't think there's a lot of overlap going on within a township or within a hospital? I certainly don't think there's a lot of overlap within the nation, so that's not a really good test for that. But am I really picking up something social? Right? So you see the three things that I'm going to try to do here. It's a lot of work for one slide. But here's your basic finding. You're going to find no effect with these randomly assigned peer groups at the national level, at the county level, at the township level. You do find an effect. It's an order of magnitude lower at the hospital, though I don't report it. And it's significant. Okay, but it's not, the T statistic is not something like 4, which is what I'm getting elsewhere, or 5. It's very close to 2. Okay, so it's barely significant. But if you just randomly pick another peer group from the same hospital, right? Remember this hierarchical structure in a township, you're going to get some significance, but the coefficient will be an order of magnitude smaller. So your elasticity is going to be something like 0.005 as opposed to 0.05. Okay? To give you some confidence as to what's going on. Now let me go and tell you a little bit about time paths. And please, feel free to ask questions. So I told you in those other regressions, I was just kind of lumping people over the last 5 weeks. We also ran regressions where I looked at the peers' behavior, the independent effect of the peers' behavior for the current week, the last week, 2 weeks ago, 3 weeks, all the way up to 4 weeks back. And here I'm just going to show you the 4-week effect because the distributed lags for 4 weeks because that's what correlates or that kind of matches the baseline results that I was going to show you. And what you see is that you find very little effect contemporaneously, not significant. These are confidence intervals. But you do find all the significant effects are from a few weeks back. I can't tell you why it is specifically. I can give you a bunch of explanations, but I cannot fix a particular one of them, whether it just takes a long time to accumulate the knowledge, whether this is just because that's the next time you actually have to make a visit decision, things like that. Okay. Here's another thing I tried. I said, well, maybe the peer effects change over the course of the epidemic, not just from pre-epidemic period to epidemic periods. Maybe during the epidemic, the strength or the influence of your peers are changing. And you do, in fact, find that. So if you look at SARS period 1, we're getting a low coefficient. That is to say, Sarah's gone now, so I guess she doesn't care what I'm saying about her, so I can say anything. Sarah cares about her peers a little bit, but not a lot when SARS first appears, when it just looks like there's some visitors coming in with SARS. But when there's starting to be a bigger outbreak, she cares a little bit more. But here's the really surprising thing, and the thing that might explain why you get this persistent reduction in visits. When the actual cases go away, you care a lot more about what your peers say. Okay? And I'm not going to tell you that this is a theory that I have and I've confirmed a prediction, but here's my kind of interpretation or feeling about what's going on. There's really kind of two sources of information. There's the objective information you can get from a newspaper, and then when that goes away, you might say, well, I need some other information. Now I'm going to turn to my peers even more. You're going to rely more heavily on your peers. And so maybe what happened here is when there was data, people were willing to look at it. And they did rely on their peers, but they were willing to look at real data. But when that went away, they really said, they became desperate for the information. They started talking to their peers a lot more. Right? So then you can get this, you can get kind of a separation or divorce from reality and behavior, or divorce between reality and behavior where people's visit behavior reflects what their friends are saying, not what the actual data are saying. It's because the data went away as the cases went away. I think that's the kind of the most interesting thing that's going on here. You're going to get a lot of behavioral response even when the epidemic's gone, and because the epidemic's gone, there's no actual data for people to listen to. They have to listen to their friends. They have to listen to their peers. Okay, so now I'm going to stop, and I'm just going to tell you a little bit about this paper. Just even the social learning proponents paper is probably just about a quarter done, so I've got a lot more left to do. And here I want to give you a sense of what it is that we're doing next. And this doesn't cover the things like, what are we going to do with ambiguity aversion. There are two other things that I want to do with this particular paper. The first is I don't want to just rely on the, kind of within the local peer group correlations that I'm seeing now. I want to try something different. And one interesting thing that I'm thinking about is that I actually can tell when you're, so while I don't know exactly your address, I can tell when you've moved in Taiwan. So I can see people that lived in one township in 2003, which of those were there in that same township 2 years ago, 5 years ago, and which of them were not. And I have two discrete predictions. One, if you came from another township, you might still be friends with people from that township. So it might be that you got your social learning not just from the people that are your neighbors now, but also your friends from the old neighborhood. And especially if it's far away, that's a really good test to see if there's social influences. So the question is, so let's suppose Sarah moved here from Cincinnati. Are her visits in Chicago correlated with the change in visits of people in Cincinnati still? Okay, the network, in fact, I know her specific network that she was part of 5 years ago, 2 years ago. So that's one test. The other test is something like this. Let's suppose Sarah just moved here. You know, there's Sarah that moved here just 2 years ago versus a Sarah that moved here 5 years ago or 10 years ago. I'd imagine the Sarah that just moved here 2 years ago is going to be less socially assimilated, let's say, or plugged in than the person that's been here for a long time. So I might imagine that the role that her peers play depends on how well she knows her peers. If she's a recent arrival, her peers might not matter nearly as much as if she's been here for a long period of time. So those are the tests that we're going to pursue. We're going to look to see if moves are responsible. The other thing we're going to try to do is we're going to try to, and that's very feasible, the other thing that we're in the middle of coding up is this idea that I'm trying to get people's beliefs about SARS risk, the peers' beliefs about SARS risk from the change in people's visit behavior from 02 to 03, right? Well, that's great in general, but I can imagine there's some visit behavior that has nothing to do with SARS risk. So let's suppose that some of her peers go to the hospital because of a heart attack. Their propensity to go to the hospital or the doctor because of a heart attack has nothing to do with their assessment of SARS risk. So I would imagine that if I'm trying to get a really good proxy for Sarah's peers' beliefs, I'd want to look at visits that might actually be responding to SARS risk versus visits that are not. The ones that are not, I should predict no effect. So if I see a change in the peers' visits in response to a heart attack, a broken bone, things like that, that should not predict Sarah's behavior. That's not that's not a good proxy for her peers' beliefs about SARS risk. Yes?
If I have a friend that goes to the hospital for a heart attack and they have a good or a bad experience in the hospital, I might learn from them that, and that might affect my propensity to go for SARS.
Yeah, so I don't think many people learned about SARS risk from people that went to the hospital and caught SARS. And one of the reasons I don't think that's the case is because the prevalence of SARS was so low. And in fact, I can be sure that that's not what's going on by looking just at the township where there's no SARS cases at all.
But I guess what I'm thinking is that there's social learning about issues other than just SARS risk, like how good the hospital is.
Oh yeah, but remember, I'm interacting with the SARS period, so I'm going to see if there's a differential effect during the SARS period.
Okay.
So you might learn about, my friend went to the hospital for a heart attack, thought that the hospital staff was atrocious and mean and rude and it took forever to do. But I would have learned that in 2002 as well as in 2003. I'm going to look at what unique stuff they learned in 2003. That's going to be the key. And I know they're learning something uniquely from the aggregate visits of peers in 2003. The question is, what if I just look at the visits that are for heart attack? My prediction should be.
There's nothing else significant except SARS going on during SARS period.
Yeah. I mean, nothing that we're aware of that was meaningful at this period. I mean, it would have to be pretty meaningful to explain this 25% drop, right? I imagine it would be reported somewhere. So that's the other sort of thing. Obviously, we want to break down the 25% drop and see how much of that is explained, how much of the change is totally explained by, how much of the total change is explained by social learning, ambiguity aversion, risk aversion, just risk, the sorts of things I was talking about before. That's the longer term project. And then I want to ask the question that I posed at the beginning. What is the effect of social learning on the development of the epidemic? And this is not an empirical exercise, it's a simulation exercise. So there are models of SARS, the development of SARS in Taiwan. And what we want to do is we want to just take those models that already exist and have been published and tweak them to introduce some level of spatial correlation in prevalence response behavior. And that we can parameterize off of the empirical results here. And then we want to see, had we eliminated, right, what happens when you set that correlation coefficient high, spatial correlation high versus low? How much longer does disease stay around? How many more people die? Things like that. Okay, and so that's the kind of project. Yes.
I suppose you could extrapolate this to any kind of emergency people respond to. If somebody have a sound here which sounds like a gun, and you run out of here, and I run out of here, everybody does. But if you know what it is, if it was a balloon and they see that, we don't do that.
Yeah.
So the ambiguity is because we don't know what it is going on, and we just act in some form of animal fugue. We respond to that without knowing exactly if this is going to be the right way or not. As time passes, we begin to find out, no, that was not really gone. And then for a visit, like a visit to the doctor, gradually decreases as time passes, because we begin to understand that was really not as bad. And it's behavior rather than a peer. Peer may be the one who was next to us, whom did the same thing and we thought we would, but we may not necessarily that I behaved the same way that I would have done. It was another city.
Yeah. So let me. I think you're saying two things, but I want to comment on the second one, which I think is the more at the heart of your question. There are two reasons why visits might have returned in Taiwan. One is the theory that you explained, which is people stayed away because they listened to their peers, and then somehow they got objective data, like a report came out saying SARS is really gone, your peers are all wrong, just go back. And then they went back. So they went back in response to objective data, or as it turns out, there was no objective data, but eventually the peers themselves, just doing some observation learning, figured out that the risk is zero. Or one of them read a report saying it's zero and it spread to everybody else. I can't distinguish which of those two things happened because I don't observe what the starting point of the information was. Which is, I think, what a question, somebody had asked that question earlier. I can tell correlations, but I know what the trigger is for any particular group? I cannot. This is a shortcoming of this literature. You might be able to get it if you had studied it very carefully, one community and rumors and things like that. So I can't answer that. But I think the other thing that you're saying about public health is, about this not being a paper that's just limited to public health is correct. I just didn't want to overclaim because I think that would be pretty bold. But I think it's very true, and I've experienced this myself, where I think we probably had the same sort of response when you think about what happened after 9/11. I lived in D.C. during the anthrax incidents soon after 9/11, and also during the D.C. sniper event. You had the same sort of thing. People didn't just read the newspaper to figure out what was going on. They talked to each other, and particularly about the D.C. sniper, because everybody was pointing out to other people, here's a white. The people were using a white van, or at least there was a concern. So everybody was just talking, there's a white van. There's a white van at that gas station. Things like that.
Or behave the same way with the stock market.
Yeah, no, that's right. And some people explain financial panics this way. Yeah.
I mean, this is fascinating stuff, but I'm going to anticipate that the response to H1N1 is not going to run parallel. At least for the fall, even though quarantine seems to be the public recommendation, if you get a cold, you get a fever, stay out of public spaces and stay home. I think the combination of availability of a vaccine and availability of a viral intervention, which is, say, Tamiflu or Relenza, in contrast to SARS, which had neither a vaccine nor a antiviral treatment, will change people's behavior with regard to doctor visits and others. Now, it may still be that your social network is what's going to drive whatever the behaviors will be, but that the behaviors will be different from this one.
Well, I certainly think you're going to go to the doctor more rather than less. We've already seen that. Right. Those are well established in data. But there are some things that are still going to be left over. So I probably agree with you, although it's easier to agree with you now that we have those things. If I'd given the talk in the spring, I think you would have said we could have a much worse situation. Correct. But there's a question of whether or not people actually think Tamiflu or other viral prophylaxis is actually going to work against this particular flu strain, whether or not it mutates, things like that. So there will be some uncertainty about this. And frankly, it could be the same thing about the vaccine. The vaccine may work well, but it might be imperfect. And the question is, what is the degree of imperfection? And you could have different groups thinking there's different degrees of imperfection, even though the objective data is going to be the same for everybody else. They're just going to talk to each other.
In fact, today's newspaper, I don't know if you may have seen it, suggested that the death toll from H1N1 might be 10 times higher than had been thus far reported. Still, the numbers are relatively low, but going from something like 1,200 acknowledged cases to 14,000 today, which is quite a shift, quite a change. I mean, one of the backdrops of information has been that this is a widespread epidemic with fairly low severity of illness. The ICUs are not being overwhelmed, and people aren't dying. But just this morning, as they go up tenfold in their reporting of deaths, it raises some questions about that. Clark.
Anecdotally, it seems to me that with the H1N1 epidemic, the place where you're seeing the social, you're seeing a lot of teeth in the social movement, information, behavior is in getting the vaccine. There's a lot of on the internet and elsewhere. I'm noticing, watching family and others. There's a lot of kind of emailing around. Should we get this vaccine or not? I heard it could be. It's not well tested. Or maybe it's kind of relevant or related to the autism concerns. And so that may be a place where you see increased exposure to the disease because people are in social groups because they're together deciding not to get the vaccine.
That's right. And I mean, so the vaccination, I think, is where it bites the hardest. That is to say, we can see it very clearly in a way that we here in the developed, in a developed country can internalize. But you could go to developing countries and you have other things that people see. So, for example, you have these bizarre beliefs about how HIV spreads and the role of condoms, things like that. They're very geographically isolated, but spread within that community. And then you could go to the next township over, or the next village over, and you don't have that belief. So that's kind of, we don't think that that's objective. I mean, we know that a lot of those things are false, but in addition, we don't think they're driven by some objective source because it's very discontinuous in the sense that there's some small discrete group that believes it and other people don't.
Is it possible or likely that people who go to the same clinic also belong to some other institutions and similar? For example, I think for the current epidemic, a lot of people get information from work. I know we do. We're supposed to stay home 20 hours and this and that. And so it could be some sort of organizational effect. Or I mean, is it likely? Is that a good counter explanation?
No, it's not the counter explanation. So what I'm trying to say is that I know that there's some real social networks. I don't observe those real social networks. There could be what church or mosque or synagogue or temple do you go to? It could be what school do your kids go to? All I can hope for with the data is to say that if there's somebody that I know that you're likely to be in a social group with, you're also more likely to be going to the same doctor as those people. That's the key thing. So there's some overlap, but I can't identify the specific network. So it doesn't defeat this. It just means that I might find a stronger effect if I could actually find the exact social network.
But it just broadens the concept of social learning.
No, it's true.
Maybe beyond where some people would feel comfortable to call it. Well, I don't know. I guess learning from whatever source is social.
Yeah, I mean, the main thing I want to know is why is it that different people, everybody in a township or everybody in a county is not going to the same source for information, right? CNN.com. Right? Why is it they're going to? And that I think Sarah had brought that up. Is that even learning in different ways can, in some sense, be thought of as social learning? But I want to be a little bit more precise and think a little bit more about conversation. So 2 hands,
So if you're looking at the content, it was a perfect segue from his question and your comment. Where is health literacy? Because if the information being purveyed is coming out of the network, and as Farr mentioned, he's seeing it in these clusters, whether it's people on the net or people in their social community or in their institution. Where is the nut of it saying, this is the real risk, here is how we assess medically your risk, and how is that coming through a filter that people understand? My impression is in that Taiwan, if they're huge consumers of health services, they're going to have, perhaps through their ministry, a high health education component somewhere through their curriculum.
Mm-hmm.
That is not the case for America.
Yeah.
And it's certainly not the case in rural areas. That's been demonstrated in the literature. So just what's the flavor? You put the slide up, future research. Where is the literacy component that's the nut of what we should be measuring?
I think that's good, too. It would be great to know how, I mean, my first reaction to what you're saying is, I think, limited, which is to think, I want to know if, in fact, having less literacy means that you're going to rely on your peers a little bit more. It could be true. And the implication for my research is that if we were to extrapolate the United States, you'd actually want to increase the amount of reliance on social learning you'd see in the United States because there's less health literacy here than perhaps there is there. That's just a projection because I don't actually know what the health. Just because they have a lot of consumption doesn't mean they have a lot of health literacy. So that's the near approach. But I do think that it's right. We want to know, and the answer to your question, not just for empirics, but also for the normative component. Can we actually, if we taught people more about stuff, to be better evaluators of data or to pay attention, read the paper more, maybe we could eliminate the social learning that could have deleterious consequences. I'm a little skeptical about that, and the only reason is because I just don't think people have a lot of time to spend to learn about this sort of thing. Epidemics do arrive, but they don't arrive so often enough, or they're not always health epidemics. Sometimes it's a public security issue, sometimes it's an environmental issue that people don't learn. And I think even in cases where people have a lot of incentive to learn, they don't learn. I bet you a lot of people in Florida and Louisiana don't know enough about environmental risk, so hurricane risk, relative to what you or I might think they should know about. So I think that's just because they've got a lot of time constraints. They don't spend a lot of time learning, or they have cognitive limitations that prevent their ability to understand more sophisticated information about the environment or health. But so these are just some thoughts that I have. But I think fundamentally it's right. You want to try to see if we can can we do to make people more or less receptive to social learning, depending on whether or not we like that. Health literacy is one of them.
There's a website. It's called Celebrity Health, and they get more hits for people to get health information than other websites that have been created to understand certain diseases. And so it's very frightening when you look at where people get their health information, particularly in the area of vaccines. I mean, there's been a celebritization of that disease that will remain anonymous.
Amanda Peet versus Jenny McCarthy, yes.
Yeah, it's just incredible.
But as it turns out, lots of things are like that. So I am in the market for strollers. And it seems just as important for a person's decision about strollers is, ratings versus, who's Tom Cruise and Katie Holmes, what stroller they use. At least that's what it appears to me. So I really want to make sure I'm doing whatever they're doing.
Today there's been a recall of 1 million strollers.
But so I'll have to figure out if they listen, if Tom and Katie listen to their recall. Because if they don't listen, they're probably right. Yeah.
Just a comment, because you have shown through your research the models of social learning, right? I believe that in small towns, big cities, people used to learn from their grandmother, parents. So I think that you're trying. So we presume we have been having social learning for a long time. But so you were trying to kind of like map the behavior, right? And find the ambiguity or the origin if there was any difference.
Yeah.
So right? That's what we say. So I was all the time thinking, how I will apply it when you're looking at it. How I'm going to do for the present epidemic, or like in Chicago, people died, 800 people of heat a few years ago, right? So I'm thinking how I'm going to use your information about, am I going to go to senior citizens, places to tell them? I mean, it's interesting. So I don't really understand my question.
I think it's a very good question.
But how do we, from the public health, we apply? But second, I have to tell you that I got scared half of your talk because you're learning so much about behavior, and then I thought, what happens if a repressive political regime, pick up all this learning from the different communities? I mean, you follow people from small town to big towns. I started to go paranoid. So it's kind of interesting, this learning behavior. What can you do? How can you kind of like tweak it?
Yeah. So I think this is related to this issue about what can you do to suppress or not suppress this behavior. I don't know the answer to that question from this research. I can look at correlates of whether or not there's more or less, and that can maybe be able to get you something. But then unless you can change those correlates through policy, it's not very helpful. Basically, I want to warn, I view this as a warning that says, if you really are concerned about spatial correlation in people's risk behavior, for some diseases you're going to be concerned more, some less. For some things like, obesity, put aside Christakis' work, but if you're thinking about obesity or diabetes, we don't think that's contagious. And so it's, the risk is linear with the number of people that behave high risk. It's not disproportionate, nonlinear. With diseases, it's nonlinear in a bad way. But in cases where you're really concerned about those situations, you're going to have to be extra vigilant to make sure that you're getting information out. That it's not enough to just get the mean reproductive rate down below 1 or to reduce the variance. You've got to actually stamp it out in these particular small communities. I haven't told you how to discover which communities have the high risk or low risk. Sometimes we can. So think about MMR vaccination. If you can find the communities that in the past few years have been doing it a lot less, maybe you can then go in and say, okay, these people have to re-educate somehow. But we probably would have known that before. So, but it's hard to figure out who's going to be the worst. You have to be extra cautious. Maybe you need an extra. You can't just settle on R not being less than 1. We have to continue with a vaccination or something like that. You've got to do something stronger than what you typically do.
Anup, thank you so much for coming over today.
Great.
We look forward to your future work.
Thanks.